seen in a long time. And then I'd like to welcome all the newcomers to the training. So we're going to start off just talking just a little bit about the history, a little bit about the values and principles, and then we're going to go right into talking about the work. I'm going to reiterate what Assad said, that we're going to make it interactive. I want people to be comfortable with being able to respond and ask questions. I always start off with the training saying that training is a place of learning. So this is where you take all your risks. You can ask questions. It won't throw the group off. Me and Paulette are here ready to interact and ask any questions that might come about. I also want to know that we always start off with asking for volunteers. But I do want people to know that I will call on you during the process. And I believe that if you're going to people's homes and you're asking them questions and you expect them to respond to you, that in training, you have to be open to responding to us. So I really want to put that out there, but also say that in the training, we don't need to believe that this is a place of judgment, or that if the answer is not the answer, that is okay, because this is a learning environment and we just want to share that information with you. We also are going to be open that maybe there are a few nuances that are maybe a little bit different where you are than they are from New Jersey. So we are also going to try to take that in consideration, the culture of your organization. Because the one thing that you are doing that is quite different from New Jersey, that I have applauded Hennepin County for even bringing into their program, is the whole cultural component. Yes, in New Jersey, we take culture into consideration. However, you guys have taken it to the next level. And so I just want to put that out there as a part of the discussion that we're having today. And with that being said, Paula, is there anything you'd like to say before I start sharing the PowerPoint? Because you will be going first.
I am ready to go.
All right, thank you. All righty, so let's see where we are. Here we go. As it loads, started from, okay, slideshow, come on. Start from the beginning. And it's moving slow. So here we go. And we'll just start here. Paulette, can you
I'm
see
ready.
Paulette?
Yes, I can. Thanks, Denise.
Okay.
We always start off with a vision when we're working with families too. In our wraparound process, the vision is the standard or what we want to see happen. Okay. And so this vision statement is about your standard or your expectation of your system. This is what you want. That Hennepin County has a comprehensive, integrated, and culturally responsive children's mental health service system that meets the mental health needs of Hennepin County children, youth, and their families in the least restrictive and most appropriate setting. That's your standard. That is what everybody's been working towards in Hennepin County. And vision statements are really important because it sets the tone for the work that you're doing. I don't know if New Jersey would have gotten as far as it did if it didn't have its vision statement and values and principles. Because if you buy into the values and principles and you agree with that vision, you become a really valuable team member because we're all pulling in this direction of creating this kind of system for the families that you're working with. So we can move on. Vision, 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 right? This is our expectation. So to create that vision, to make it happen, family response and stabilization is a huge part of that. And I will tell you, in New Jersey, mobile response and stabilization, that's what we call our group, is one of the most popular service entities in the state of New Jersey. Families love mobile response. And I'm sure Assad and you are probably also hearing that your families respond very favorably to your interventions. Being in the home of a family within an hour of them needing help is unbelievably wonderful. Instead of floundering around trying to figure out what to do or calling the police or ending up in the ER. So you are one of the pillars of the system of care in Hennepin County. You're an immediate in-person response, right? Um, with family response and stabilization. There is also the wraparound services, the things that are put around the family when they leave FRSS that allows them to sustain, hopefully in the community, right? Least restrictive. We know sometimes that's not always possible, but that's our goal, the least restrictive environment. And to do that, we have to put sustainable resources in place for the family, which means natural supports, the people that are close to the family that can provide the day-to-day or the resources that they need, whether it be emotional, physical, concrete, and then the informal and formal supports and services. So it might be a therapist, it might be outpatient, it might be whatever. But that wraparound of services and resources is really important. And then you have a service continuum from identification of someone who needs assistance to intervention, and then maybe even intensive in-home therapy. So you have a service array out in the community that hopefully as time goes on, you can really dig into more and more. I know when we first met you, it was the idea of, we need to really get out in our communities and see what's there so that folks, we can offer people resources that might help them remain in the community and develop their strengths and stay in their communities. And when you see that word intervention, that word is really important because it's not just services. I have been in team meetings where there's not one formal service provider on the plan, but there are community resources and informal supports, informal being the people we can stay connected to as long as we both agree to it. It could be the pastor at the church, it could be a Boy Scout or Cub Scout leader, but the interventions don't always have to be service related, which gives us more opportunity to be creative and individualize a plan, which is really important. So you are one of the key pillars in your system of care. And the growth that we have seen in what have we been working about a year and a half, Denise, is unbelievable. It's just so nice to see the expansion and how you're getting integrated into the community. So here are the values. The values are how you think about the work. So you are youth and parent driven. That means your families and the children and youth in your families are definitely a big part of the planning process. They are driving the plan with their needs and their strengths. Okay. We put them first and foremost. And the reason this is so important is your families in particular are coming to you in crisis. We have to do everything we can to help them feel comfortable in participating in their care. We know that we have to do some de-escalation and regulation, but as much information as they can take in and as much as they can participate, they are the experts on their own lives. And so they are core centerpieces of our values. We want to engage with the community, right? The community resources are really important for sustainability. We want to be trauma informed. We know that a lot of the folks that come to us, and I know in our system of care, a lot of the families we work with have trauma. How many of you are dealing with families that have a fair amount of trauma? Raise your hand. How many of you work with families with trauma? Okay, so almost everybody. We want to use data to inform our decisions. It's not just guessing. But do we have some hard data? And I heard Assad mention, looking at data, how critical that is to be able to really improve on the work that you're doing, look at trends in the community, look at the service delivery. It's just so important. And instead of guessing or, using that gut, it feels this way. It's not about feeling. It's about what can we show in data. It's also very important to sell your service to other community members and to other providers. We want to integrate our care, that we are working alongside and with and collaborating with other services in the community. We want to integrate the work that we're doing with other people. And you folks have taken this again to another level. We want to be culturally responsive. So these are our values. If you don't agree with any of these values, you will struggle in a system of care. It's just that this is how we think, and this is how we approach our work. Okay, these are our values. And next, we're going to move to the principles, and this is how we actually put the values to work. All right, family, voice, and choice. Nothing about what we do happens without the family and the youth weighing in. Okay, their choice is really important. Culturally competent. I know Denise, competent is always a word that I struggle with when we attach to culture, because all we can do is be responsive and respectful. I don't know if we ever become competent with culture, because people have a lot of intersectionality with the cultures that they participate in, right? We're not just one thing, and we change over time, and depending on, where we are, we may be part of another group. We want to be community based, where we are the least restrictive. We want to keep people in their communities. We want them connected to their communities. That culture piece, again, is very important in that community piece as well. And strength based, always looking at strengths. In fact, when we do process, we often here in New Jersey, we always start with the vision. Where do we want to go? We all agree this, with the family's vision, this is where the family wants to go. But then what are your strengths? What can we use in your planning that you bring to the table, your everyday strengths? And that means you too. You too, as workers, bring your own strengths. And it's not just your work competencies. So if I asked someone, and if somebody wants to volunteer, what's a strength that you bring to your work with families that maybe not work related? Not I'm great at doing the cans, or, I have my degree and I can interview, but what is some strength that you bring to your work with families? Anybody? Go ahead, Katie.
Go ahead,
No.
Katie.
Sorry. Are you sure, Coco?
Yeah, go ahead. Where is my lady? Yeah, Katie.
I've been told by clients, parents, and kids that I'm relatable. I do self-disclosure appropriately for the most part. Yeah, actually not for the most part, I do. And then sorry. And it's that Minnesota self-humbling thing. And then but yeah, the relatability, that informal professionalism kind of thing. Like, you're in somebody's home, nobody wants you looking like you're an FBI agent or something from Men in Black. They just want you being relatable and not judging them in their own home. Like, it's already uncomfortable asking for help.
That's one, that's a really good functional strength, being able to tell a story in an effective way, right? With a family. Wonderful for that engagement piece. How about somebody else?
I'll go. I
I
would
love
say
it.
giving them
Karina.
compliments of their home, or like the decor, and a sense of humor. Yeah.
Wonderful. In this type of work, that's critical, right? Being able to use humor in a situation, right? To lighten the load there. About other folks.
I also like Paulette that she said give compliments, but the compliments that she giving is a way of actually connecting and engaging with someone, and that's really important. That's like really important to be able to make that connection, because when people are struggling and they're not wanting to talk, sometimes we have to go to those areas of commenting on other things to bring the relationship into fruition. So thank you for that. Go ahead.
How about one other person? The strength you bring other than your work skills.
Cultural understanding on my part.
Mm-hmm.
Can you explain what you mean a little bit more about cultural understanding?
Mm-hmm.
Yeah, so I guess personally, I was born in Eritrea, Northeast Africa, moved here when I was 9. So being daughter of immigrants. I understand the expectations as a daughter of an immigrant, the, requirements and what family values that may differ from some families. So pretty much that.
Love that. Thank you very much, Luan.
I just want to share one thing about culture, although Paula, I'll let you go past that. But since we're talking about culture, I want people to recognize that one, that culture is fluid, that people have the ability to opt in and opt out of cultural practices, even if those are the practices that they have been raised under. Why I'm bringing that up is because many times when we're working with children and family and their caregivers, many times the challenges that we're responding to in home may be connected to cultural practices, that families may come here or have cultural expectations of their children, and their children are now opting out or trying to test new waters. And when they're starting to test those new waters, that starts to bring in a lot of stress within the household, because the youth might be trying to develop new cultural identities. They might be engaging in other cultural practices that would not be normative for the family that they're from. And that might be the source of the challenges that the child and the family are having this at a point. So for example, a child is wanting to do something that culturally would not be expected of that child within that family, but because that child has now learned connected with people outside of their culture, connected with people who do things differently culturally, because even within families, people can have their own cultural practices. I'll just use my family for example, and then I'll move on. I was raised as a Christian, and as I grew up, I continued that practice. I have a large family. I have many family members who are not practicing Christianity. They have moved on to practicing Islam. That can become a source of conflict within the family at different times. One, because a caregiver may not respect the change of religion, or it could be just other practices that happen. As I enter into adolescence, I start to want to become more independent. I start to want to do things differently from what my cultural practices have been at home. My expectations as to what I should do, especially in families who may have been immigrants, but I see this across the board. You raised me to do things one way. I have now come in contact with other people who are doing things differently. And now that's becoming a source of conflict between me and my caregivers, and maybe even other people in my family. We need to be mindful that's why I talk about culture being fluid. And we need to be mindful for a lot of young people that comes into play. So culture comes into play in a lot of different ways that we might not think about it. We might think about it as someone just breaking the rules, but it might really be a cultural practice that's not being adhered to, that's really creating a lot of challenges in the household. And that's why culture is so important. Okay.
Culture can even be subtler things, like, I'm
Mm-hmm.
an older person, and when I was working in my agency, the care managers were mostly young people, pretty much out of college, and they love texting. I do not like texting. I don't check my phone for texting. I prefer phone calls or emails. And it was like, well, I sent you a text. And I'm like, I don't like, people are so tuned into their text messages when you're younger, and it's not something. So even subtler things are how you address people when you enter a home. Sometimes we can think it's okay to be informal, but for some places or cultural norms, they prefer a more respectful, addressing, like they would prefer Mr. or Mrs. rather than Sue. So those little things can make a difference too in the engagement piece. All
Okay.
right.
All right, I'm going to go back to sharing.
Feel free to comment, or if you have an example from your own practices.
Am I sharing?
It's coming, I think. Yep, there we go.
Okay.
All right. So that's strength-based, always looking at the strengths of folks, and team-based. Our work is about collaboration. We really can't work in silos when we're in a system of care. You really have to be able to work on a team, develop consensus, have difficult conversations, and you'll still maintain those connections with people so that you can do the work for a family member or a youth, right? So that team-based, those skills are really, really important, along with the collaboration. And we're always looking at outcomes. We want to be able to measure the work we're doing, so that when the caregivers and the youth that we're working with leave us, that there's a good outcome for them down the road, either down the road because they're moving on to a different service now to continue their journey, or they have a good outcome with us and we're transitioning them out of care. So it's always about outcomes. There's no point doing the work if there's not going to be change involved. Most of us got involved in this work to be able to help people change something that is not working in their lives, that is causing them stress, that is causing them a challenge, right? And we want things to be better at the end of their time with us. So we're always looking at outcomes and checking in periodically with progress. And a lot of the paperwork that you do is about tracking progress over time. And individualized is another principle. I was just talking to a group that said with COVID and the busyness, that a lot of their plans started looking the same just because of time constraints. And so when you start seeing like cookie cutter type planning, you're using the same services, you're using the same providers for almost all your families. You can't tell when you pick up a plan whether it's for an older adolescent or a younger child. We need to kind of step back and say, where are we losing that ability to look at people as individuals and make a plan that is tailor-made, right, for the youth and family that we're working with. Natural supports, that's a big calling card for system of care. People want to have sustainable work, they want to be able to sustain their progress in a community. And those natural supports are what allow us to do this. We know families that have providers in their lives, and they're the only people they know to call when there's something going on or there's a challenge that hits the family. I always feel for those families because they're always in care with a provider. They don't have people outside that do the things that we ask our family and friends to do for us. Can you babysit for me? I'm really struggling. Can I talk to you? Those kinds of people that we have in our lives are intimate people, our family, our close friends. Maybe it's a neighbor we're really close to that we can go to and either get some concrete needs met. I have a person I could borrow $5 from, but I also have somebody that if I have to go to school and pick a kid up, they can watch the baby, right? Those are the kind of concrete things, but also the emotional supports. And we need those natural supports if we're going to sustain our progress in a community. And unconditional care. And for me, this one is really kind of personal because for me, it's about not giving up. And I did have a provider one time that told me there was no hope for my situation. And I can tell you that that was a devastation because I thought to myself, if an expert is telling me I have no hope to improve certain things in my home, I don't know where do I go then, right? So we are the instillers of hope. We keep trying. If something doesn't work, we go back to the drawing board. Let's figure out something else, right? We sometimes walk along with people during those difficult periods. We're hand in hand and we're partners during those dark times when we're really trying to figure things out and things aren't going well, but we don't give up. All right. Because hope, there's no point. And I'll just tell you from my standpoint, and I know Denise and I talk a lot about this. If you don't have hope, it's hard to engage in treatment. Right? Why put energy into treatment if there's not going to be a change that'll help you get out of the situation that you're in? And I don't know if any of you know Basil van der Kolk, who's a trauma expert. I'm sure some of you do. He always says that when you're doing treatment with people, when you're doing interventions, when you're engaging with people to help them, we have to be hope merchants. We have to sell hope. And sometimes when families are really devastated and feel like there is no hope, we have to go in there and be hope merchants. So,
Paulette, I saw Samira had a hand up, so I want to
oh
give her
yeah,
a
go ahead,
chance
Samira.
to
I'm
ask
sorry I didn't
questions.
see you.
That's why I'm paying attention.
So my question is around the outcome based, right? Let's say I get this family that I work with for 8 weeks. Within those 8 weeks, the goal, let's say, is to get the people in the family to day treatment. Let's say there's a long wait. Within 8 weeks we didn't get into day treatment within that time, or we apply for medical insurance. Within 8 weeks we're still on the waiting list, right? So if we're measuring outcome, right, how will that outcome look like? Because for sure the family will be like, thank you, Samira, you have been great, you meet with us. However, we did not get the outcome we needed, which is to day treatment or to this, to that. So
I
what
would
would that
say
look
you're.
like?
Go ahead, Paulette.
Go ahead, Denise. I have my own thoughts about
I
that. But go ahead.
believe that many times when we look for outcomes, we look for services. And really what we need to look for is there a change in coping skills and the behavior and to manage things. A service is somewhere where we place someone. So we could still try to get them in the service, but when we're really writing about an outcome, we're talking about what it is that the family should be able to do a little bit different. And we'll talk a little bit about that more so as we move on through the process. But that's a question because many times when we're writing plans, in mind, the outcome is a service. When in mind, really the outcome should be what is the best coping strategy? How is the family able to get along better? Whatever it is that they need to do, the service is how they're actually going to reach the outcome. And I don't know if that's a new way of writing plans for you or not. And so we could talk about that later on. However, then we need to go back and have this discussion about what happens when we're trying to keep people in service, in stabilization, and we still have not been able to get them in the service that they need to improve their health. That is something that maybe later on we could talk about with the side and the and Nexus and how that works together as a way of moving forward. But when we talk about outcomes, we really want, because how are you going to measure if someone outcome is to get them into service? The measure is either they get in or not, but it really doesn't talk about any real improvement that is going on. So the way when we think about writing our plans, it needs to be based on the improvement of the family in the process. However, the service might be something that we would transition somebody into. Any questions or comments about that?
Yeah, and when you mentioned that the family was talking about how much you help them and so forth, even helping them articulate what they've learned, what they do differently now that helps them keep the situation from being what it was before, that's the progress, that's the outcome. And as for response, think about response with a 3-day turnaround, right? Your outcome is the de-escalation of the family and putting things in place to help the family, de-escalate to a point where they can now move into either, if they need intensive services, move into that continuum or can move forward with stabilization. But sometimes I think we don't focus enough with the families on the improvements that they make that have helped them not go back into crisis or need that same level of intensity they did when they came into response.
Okay, aside.
And then, yeah, just one thing I wanted to add to those, the outcomes or the data driven. within our program infrastructure, we have a multiple layer of data we're tracking. One of it is what does SAMHSA need of us? And one of those tools is the National Outcomes Measure, or the NOMS, so that when families are coming into service, we have a baseline of how they're functioning. What are some areas that the family is struggling? And then as family ends or transitions out of the services, we have post-intervention NOMS. And when you compare those data, and just look at the qualitative data of families are feeling a lot more hopeful. Families felt that their culture and linguistic and religious and all those other factors were respected, that they felt that the plan was co-created rather than created for them. So all of those things, yes, as you lay some of those system level struggle of getting families to connected to those, we're also trying to account and gather those information. But what often is overlooked is the family, how they're doing now compared to how they were when they first came in.
They're not the same family. And, you know, the other thing, having been a family member, and I was also the executive director for a family support organization with peer groups that went out and supported families. Families get real sensitive when they're starting to transition. They get nervous because they start feeling better and they feel like they're managing better. And now they're leaving a service that really helped them get there. Okay. And now I got to leave Samira. And oh my gosh, you know, will I be able to sustain this progress? We always have to keep that progress that the family's making in front of them. And that's why being very descriptive, getting information that's descriptive and showing progress along the line. And I'll give you an example of this. If a youth is really having a lot of temper tantrums and you define that with the family, they tell you what that looks like. He's having 3 or 4, they last a half hour. He's screaming and throwing and he's on the floor and he's inconsolable and it's an intensity that involves the whole family and blah, 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 blah. And on one of these episodes, they call family response. Over time, you know, the caregiver learned some strategies. There's some deregulation strategies put in place for the caregiver and the youth. And we see those intensities dropping. The time frame is getting less. The flailing is getting less. Maybe he screams and cries for 5 minutes. That's improvement. But if you go into that house, like right after the child has one of those 5-minute things, the caregiver may say to you, see, he's still having those tantrums. He's still, you know, he's still doing that. You have to keep pointing out 5 minutes versus, right? We have to keep saying, wow, but look, you handled that 5 minutes. Remember when it was a half hour, a few times, you know, a day, and it involved the whole family, you were able to manage that 5-minute, you know, to do. And yes, it's upsetting because you're worried that it'll, but you managed it. You're doing great. You know, like you have to keep putting that in front of them because families, especially during transition periods, they start getting nervous that they're going to go back the way they were. It's really scary when they start transitioning.
And I just want to say that that's why measurable plans are so important because that's how families can see that change has occurred. Okay. And that's why when we're doing the work, when we actually hear a behavior that a family is complaining about that is recurrent over time, we need to stop and ask, how often does it occur? When does it occur? Because if we don't have that information, we're operating in generalities. And the one thing that doesn't work very well in treatment is to operate in generalities. We need to operate in specifics. What is going on? What does it look like? How often does it happen? When does it happen? Because sometimes when we ask those questions, we get to be even more creative in our responses, but we have more information to address the issue with. If a child is really struggling every day when they come home from school, then we know that part of that struggle might be related to this child going through transitions. There you go, Tamara. And where other people might not think about it, but it might be the transition of leaving school and coming home. And people might think the transition might be related to coming home when it might really be a response of the trip coming home, because we found that children many times can do very well in school. But when they get on the school bus, if y'all use school buses, and so I'm only, if I'm not in your neighborhood, correct me. Okay. So when the child is transferring, coming home from school, the structure from school to home has changed, and the child might not be able to operate clearly in that structure. Another challenge could be, and then I'm going to move on, is that the child has come home, has maybe had a fairly good day, but now they're coming home and they need some attention from their caregivers, or they need something to eat. See, that's why we have to really ask about all of those areas, not being hungry or coming home and being overwhelmed from school and now being directed to go right in and say, let's do your homework, can also be triggering for a young person. And unless we ask those specific questions about what happened right before the child acted up, is this something that is happening on a reoccurrent basis, we can really miss some really good information. And then when we come into the homes, we are trying to deal with just what we see. And I'm trying not to go ahead of myself, but because we are here having these conversations, I just want to say this, and you're going to hear me say it again, that behavior is communication. What people do, how people act, they are telling you something. And we have to slow down that process sometimes and find out what is that behavior about, because all behavior is communication. And so we have to look at it from that perspective, that all behavior is communication. And what is this behavior telling me? Back to an experience, and I'm going to move on. Again, as you know, I ran mobile. And I had a large staff because I had 6 counties at one time. And I had this one family that every staff in my 6 counties had responded to their household. And by then I was like, okay, everybody's missing something. I need to go out and see what they are missing. And I got information from protective services about the family. So even some of the information that I got from protective services was a little skewed about what was going on with the family. But I went in and the mother was all irate and hyped and everything. And so I calmed her down and I sat down and I started talking to her. And I told her, tell me what's different about today than every other day. And she said, you're the first person to sit down and say, tell me what's different today than every other day. And tell me what a good day looked like and what a bad day looks like. And from that conversation, I start to see that there was some things going on with that child that day that were triggering within the household. And the mother thought she was doing all the right things. But it was just taking that moment to see what that day looks like, because learning what someone's days look like will give you information about the caregiver, and it will also give you information about the youth. And sometimes the lack of attention from a caregiver can cause a youth to act out, okay, or vice versa. So it was just an interesting thing that we learned. I also went in the family with a lens of substance abuse. They said there was no alcohol use within the family. No, there was not. What was happening? That the mother was taking her children's medication as a way to calm herself down. So now the child was not being what? Medicated. And so that was a whole new issue that we had to address. And so I'm going to give my last little tidbit and then I'm going to stop talking. Another thing that I've learned, that parents were quick to tell you that their children is on medication. There's two things we need to do. We need to know who is administering the medication, and if the child is administering the medication themselves, because a lot of times parents will tell teenagers to manage their own medication as to give them independent skills, but they're not checking to see if the medication is being taken as prescribed, and that could also lead to other issues. So I'm just throwing a lot of things out there at you. I'm sorry, I can't help it. When I think about things that actually come to mind in doing the work, I'm going to put it out there. But those are things that we have to be mindful of. Those simple questions. Is he on medication? Yes. Yes is not enough information. Knowing who's giving the medication, who prescribed the medication, those are questions you need to ask when we get responses to yes. And does the family see the medication as effective or helpful? And we need to ask that question from the youth and from the parent. Because what we miss a lot of times is that youth will stop taking medication because of the side effects connected to it, and they won't say a word about it, just like any of us. Or they start feeling good and they no longer feel they need to take the medication, just like many of us. How many went to the doctor, had some type of cold, infection, I don't care what it is, you take it, you start feeling better, and then all of a sudden you stop taking the medication? Okay, now let's not even add the cultural component that I come from a family that really doesn't take medication only in life or death situations. I'm just putting it out there. So we have to be mindful to think openly about those things and ask those questions, because those are the things that we sometimes operate in generalities about. And those are the things that after over time, we're wondering, why is this not working? What's not happening? We haven't asked the information that would give us real specifics about what's happening, and so people continue to do things the way that they're doing. Any questions or comments before I move on? Okay, Paulette, because I know I'm looking at time also.
No,
Oh, okay. All right, I'll keep moving on. I'll continue sharing.
Thank you.
Please feel free to break in. We will get through all this no matter what. Go ahead. All right, here we go. And I'm going to move to the next slide when it comes up. Okay, okay.
So, why do you exist? What's your purpose in your array of services? And this is quite an interesting list, and it's a very important list because you're there to assist children and families in managing crises in their life within their own environment. They don't have to go to an emergency room. They don't have to go to another institutional setting. In their own home where they are most comfortable and where the crisis is occurring. You're also decreasing the number of ER visits of children, which is huge. And I don't know if you've ever had the wonderful opportunity to sit in an ER for hours and hours with a child who is out of control initially, then calms down, then when seen, says he's okay to go home, and then you go home after all that time spent. But emergency rooms are they're not the place to be able to work with these types of situations. We're a lot better able to address cultural needs within the home of the family, right? And we can identify resources and supports within the home that will aid the de-escalation and self-regulation of the family, noticing what's around the household, noticing what's going on between the dynamics between the family members. We get a ton of information by being in the home of a family. And we also can provide an earlier response before things start getting to a point where they need more intensive services. So if we can get in early, when there's a smaller crisis going on, we can maybe avert something just being unattended for a period of time till it blows up and it's something very big. It's a lot easier to deal with a youth who's experimenting with marijuana than somebody who's already moving on to a harder core drug or injectables, right? So if we can, deal with a concern early, we're much better off. So you are a very important service in the array of services in your community, and you will probably one of the most loved and valued by your families just because of your availability in the moment.
Okay. I'm sorry it's not moving for some reason. Okay, there you go.
What a system of care requires is a paradigm shift. It's a move away from a medical model. And as a nurse, I grew up in the medical model where you had the lead team member was the physician. He was the, quote, most educated, and he was the one who gave orders. And the rest of the team followed the orders, including the family and whoever was being treated in the family. We don't do that anymore in system of care. The family are the ones that determine what they need. When they call you, you're not telling them what's going on. They're telling you what's going on and what they need help with, right? Professional centered services, medical model really is looking at deficits. What's going wrong? What's the disease or the disorder or the diagnosis that we're dealing with? And what protocols do we put in place to deal with that challenge, right? Here, we're looking at family strengths and interventions aimed at strengthening the family to deal with whatever needs they've identified. It's a whole different approach, right? We're not correcting deficits. We're strengthening the family, and we're also individualizing to the family's uniqueness. Interventions in a medical model will often be what's available, what the protocols are. What's professionally available. And I've seen a lot of times, like in schools, you'll see this a lot, where if there's an IEP, it's not exactly what the kid needs, but this is the type of autism service we offer at our school. It may not fit the child's needs. And sometimes you'll hear families say, but that's not what my child needs, but that's what we have, right? That's the best we can do. And so, what we're charged with is really coming up with interventions that move the needle for a family, that are individualized to them so that their needs are truly met, that we find the right services and interventions. And I always use that word interventions because it doesn't necessarily have to be a service. And in medical models, oftentimes there's not a lot of say, low levels of decision making by the people we're serving, whereas in family driven and youth guided in systems of care, the family has a high level of decision making power, right? And so we really have to switch gears here. So if you need to be an expert and direct and solve problems, you'll struggle a little bit with that family partnership. This really is about partnering with the family. And when Denise was talking, you were giving an example, Samira, of the information. The family is the expert on their family. When you ask questions about what was happening before and what do you see and how blah, blah, you're getting information from the family because they're the experts at what's going on in their home. And you need them in the planning, right? So we really elevate that expertise of the family and their strengths in our planning. So just keep in mind, it is a little different than the medical model. And that's why other service arrays may have problems with system of care and collaboration because they're used to being the expert, okay? And I've had, some people come on that way that they're the experts and the family needs to listen to them. And it's a little bit of a shift. We have to, kind of work with that a little bit. So here are the stages of family response. You have your initial call, there's the response, then stabilization if necessary, and then we transition out. We can move because we'll be dealing with this more. All right, and here's our process on the call. And I hope, is this still your number? We were going to check with that. Is that still your number? Yes. Okay. When you get on a phone call, that engagement, how do you connect with the person on the phone call, doing your safety check before you go out, weapons in the home. I know you have protocols for that. Identifying what is the crisis, getting the demographics, and then going to the home and responding. and that whole process that happens there. It's a 72-hour process. And here are the roles of the response worker and stabilization. You're going to be getting this PowerPoint, so for time reasons, I think I'd like to, move on, because you'll be getting this information from Kayla and your supervisors. For stabilization, your coordinators and your supervisors, but these are definitely your roles in the process of response and stabilization.
You want me to, okay.
All right, first 72 hours. This is response. Your response within an hour, or a scheduled response. If the parent or caregiver or whoever's in charge is asking for a scheduled response, maybe when the youth comes out of school, you hear the story. You respond to the specific crisis. You may say a million needs, but you're responding to the crisis that was, the family's dealing with. You de-escalate, you complete the family care plan. You do your crisis assessment tool and create an action plan. And then there's a referral, whether into more intensive services, stabilization, and rarely after 72 hours, it may be that they are done after response, and then a transition process.
Mm-hmm. Okay.
Okay.
Are there any questions about these first 72 at all that we'd like to talk a little bit more in depth? I do like to say that we try, no, I have to make sure y'all not doing it that way, because I'm going to say we try to respond to a call right away. Our focus is not to schedule unless someone absolutely cannot have that response within 1 hour. For example, maybe someone is at the emergency room and now they're being discharged, and they're saying you need to contact family response. So then that would be a time where scheduling would be really important, would be something you would do. Or I'm not sure, so I'm going to go and go on the limb. Or maybe there's something going on at the school and I can't remember, so I have to put this out here, where does the school require the parent to come before you can come before the response? That's what I thought. I just want to make sure I'm on the same page with that. Then maybe that would be a response. But you have to be very careful about scheduling, because sometimes scheduling can be a challenge where people will try to schedule for their convenience. We are a program that are really supposed to respond in an hour. When people call you on the phone, you really can't tell how much of a crisis they are in by how they talk on the phone, because people learn to manage situations based on past situations. And I'll give you, I can become really excited about something, but I'm nowhere near in crisis. So if you don't understand culturally that I could be really excited about something, you might read my excitement as crisis over the phone and say, okay, maybe we can put this off to later. Flip that whole thing. I have been a person that when I'm in crisis, I get very excited, but I notice people don't respond to me as well as when I'm excited as when I'm calm. So over the phone, I've learned to get my point across is that I have to calm down in my response so I could share that information with someone. That doesn't mean that I'm not in crisis. Does everybody understand where I'm coming from? So we can be, I've seen this happen many times. Someone might be responding in a way that doesn't seem appropriate to you in how they should be responding. And so then we might minimize or over exaggerate what is going on in their life at that time. We have to just go with, if someone calls in and says, I need someone to come out, then I'm in crisis. One, because the family is the one who identifies the crisis, not us. And sometimes we will hear a story And I'm telling you, we will hear a story that on the phone doesn't sound like it should be a crisis because it's not a crisis for you. And you believe that people should have the coping skills and ability to manage that crisis, when in fact, it might truly be a crisis for them. I'll give an example of one that I had to really talk to my staff about. A woman would call every day and say she needed help. She called a couple of days saying she needed help to get her child out of bed to go to school. And so what we learned after we responded was that the woman never got her teenage son up out the bed to go to school, because she always had someone to support, a nanny or someone who lived in the house whose job it was to do that for her. When the person who took care of the household quit the job, the mother didn't have the relationship that was necessary to tell the child what to do. So the child wasn't listening to her because he spent most of his time listening to the caregiver or the nanny that was present in the household. So now for this parent to get this child to school, it truly was a crisis with her, because we had to help her develop the skills to interact with her child in a way that would support um, him getting up and preparing for school. And so in the beginning, it sounded like something that was a very simple problem. Why can't the mother get a child up out of school? All you got to do is go and then tell them, when in fact, there was not that relationship that was necessary. And every time she said something to the youth, one, he was angry because he felt the person had left because she didn't like him. And two, she never did it before, so they didn't have a relationship. So in that household at that time, that family was really experiencing crisis. Now, this was a household where the family were extremely affluent, and for many of our our response workers, that was not their environment, and they didn't understand that situation at all. But we had to still support that family. It was their crisis. The family dictates the crisis, and we need to be mindful that we can't always tell if somebody's in crisis or not, even if we're looking at them on videotape.
Go out. You go out.
You can't tell. You have to go. And so I like to be real clear about that. Okay, Asad.
I really like how you use that example, and I have been able to steal that from you for some time, because oftentimes people kind of are easy to make a judgment on somebody, and they would assume maybe this is a life of privilege and the mother or this caregiver should have these skills already, not realizing the relational piece is not there, both for the child and the mother to function the way, and there's an adjustment going on. So to see that is our mission is to say, and vision is to say, no reject and no eject policy. It doesn't matter how small the crisis it is to somebody who is listening on the other side. There is nothing that would make a parent, as a father myself, that would make me call for a crisis unless I know I'm not equipped to deal with. So at that moment, if the parent is making a call seeking support, it's not on us to determine what is a crisis and what is not. Our job is at that moment to gather information necessary for us to be able to go in person and be able to support the caregiver and understand more from a holistic approach rather than from our singular lens of I'm making these connections of this is a parent who is privileged and not able to, raise a child. So I know, Kayla, you have your hand up too, so I'll hand it off to you.
Thank you, Asad. Denise and Paulette, I would like to kind of circle back to the immediate response, right? Not setting up appointments. And, we do see oftentimes lots of different reasons why folks want to have something scheduled for sure. And, a lot of reasons have to do with just being available. And we do try and accommodate all of those requests. As far as a programmatic piece, what is your recommendation on actually scheduling, and how far in advance would you schedule? And what would be some reasons why you would, but what would also be some reasons why you wouldn't? Again, considering that we don't have that eject reject policy that Assad just mentioned.
I would, if someone is telling me that I need to schedule a day or two later, then I would talk about, is this really a real crisis? Okay, because crises are supposed to be immediate response. And so I would have to share that. Why would someone call and want a crisis response 2 days later? One, because the crisis, the period of crisis, if we go into that cycle, it can waver back and forth. We should be almost all responses, unless there is some real issue that's coming into play, should be taking place right within 24 hours. Or
and then also
otherwise,
remembering that our population is a little bit different, where we're also not just doing that immediate crisis, but we are trying to work from that upstream approach. So we do also put our services out there to folks to utilize when they're not necessarily in that crisis. And so that's where I think we see a lot more of those, is where they've been seeing and noticing some, troubling behavior, or they may have been given our information from a screen out team at Child Protection Services or something. So there isn't a certain situation that has arisen, but there's just other things going on, and they kind of would like somebody to come in and connect with them prior to it escalating to that crisis. Example, just this morning, one of the calls that I received was from a family who received our information from a screen out team at Child Protection. It was a situational behavior happening, and I took the information and scheduled not this Sunday, but next Sunday, which you said, that is not a crisis. I did also forward her some information. She wanted our, our flyer and stuff, so she could reach out if something were to happen and we could respond in that immediate piece. Mm-hmm. There has been previous situations where she did need assistance, where she contacted law enforcement. So, we talked a little bit about that and how we could take the place of that piece. So in those situations where, yes, there has been behavior that would escalate and meet that immediate crisis need, right now we weren't at that point, but definitely wanted to kind of connect with us to see how we could help in those moments, but also what services we had to offer and just some things like that. So I feel like I asked a lot of questions in that, but kind of what would be your input to some of those?
I still, if Protective Services would have said this person needs to reach out to us in New Jersey, so I'm going to be real clear about it, that would be something that we would need to respond to immediately. It wouldn't be something that we would be allowed to screen out a week ahead, because then it would be seen as a crisis is not occurring at this time. And all of our responses are always crisis related. If I love that you're giving the information out, because we had to give that information out, but we also had to find other resources if someone wanted to extend a time, that maybe there were other places that they could contact and other resources that they could use. But because we are a crisis program, for us, all calls would be identified at time of call, and the response would be expected within within probably 24 hours. So I'm just saying, from our process, it would be, you need to call when there is something going on, because we are not going to provide resources that other agencies, and I'm saying this is different for your environment, but we're not going to provide other resources that other programs could provide if it's not connected to crisis. One, because when we respond to a crisis, we are going to have to complete a crisis assessment tool. We're going to have to do all the things that are connected with it. And if it's if it's a week, then we would say call back when you need us. That's what we would say. Now, I understand your upstream approach, and that is something that you guys are going to have to manage. But for us, everything is pretty much crisis related.
Thank you, Denise. Assad, oh,
Yeah.
good. I was going to ask, Assad, would you add anything to that or have any
I think
perspective?
as we're tracking the number of families we served, which is at this point not including the January 2024, 720. And I think these are very small outliers, but this is something that at this moment we're tracking to see, because how we envision family response and stabilization is also an access point for all children crisis response, right? And what's happening in communities is, as Kayla shared, is families will get the resources about FRSS. Maybe the person who is sharing with them identified a pattern of maladaptive behaviors. Maybe the parent at this moment might not even recognize that. So as that person is given information about these resources, what they want to do is call in and confirm if this is really truly in existence. And if it is in existence, can we call and schedule something? So we've been able to schedule, we want our services, majority of our responses are within 1 hour. We see families that have called that is scheduled further within that 24 hours, but also something that we want to track on if families are calling and scheduling 7 days later, could we be able to connect them to the child access line or the front door? But again, having one access point where we're kind of gathering information and identifying this is a family, we're sending somebody out, this is the family, we're scheduling something for tomorrow, and this is a family that needs 7 days later, and how can we connect them to those accesses and services? Again, those are very small outliers, but something we're interested in tracking and figuring out how to support them as well.
Yeah. Because what is different from New Jersey for us than it is for you is that we have a system. If a person is not in crisis in New Jersey, they would never even get called, sent to mobile response. So that's why I'm trying to say that we are different. And so for us, anything beyond the 24-hour would be you need to call back. And maybe we can our system would be able to provide other resources to their families without any connection to mobile response, because our system is different.
And I have seen families get very slick where they call back with a crisis.
And that's fine, but they have to have for us it has to be crisis related, because for us Medicaid funded, we're funded quite different from you guys, and so all our crisis programs are actually funded through Medicaid, and so you have to be in crisis to get paid for that funding.
To justify it, right? Yeah.
Yes, you have to get Medicaid or state funding, because we take everybody. But yes.
Thank you, Denise.
When care management organizations got really tight, people were calling in with crises because that was they thought was a fast track into the care management organization. Families get a little savvy after a while, learning how to maneuver, you know what I mean, to get what they need. So you have to watch those trends too.
Okay. Any other questions before we move on? Okay. We're going to talk a little bit more about these 72 hours as we go on. So here is it. Go ahead, Paulette.
Go ahead. No, you're okay.
Okay, so here is just a list of what maybe 72 hours would look like. It doesn't have to be exactly as written, but these are some of the things that should actually happen within 3 days. One, you should receive your call. We have a 1 hour response or schedule. We also want to talk about that when you respond to the home, there really should be no time limit on that first response when you get there. So it does it because you have that 72-hour window. Getting there can take some for people. They can actually de-escalate and support a family within 2 or 3 hours. Others, it might take a longer period of time, but there's no time limit on it. When you get there, engagement must occur. The work doesn't happen without engagement. We just have to really be mindful of that. So we need to hear what the family has to say, what their story is, and we need to identify the crisis. We need to, one, hear the story not only from the caregiver or parent, but we also need what the child's version of the story is also. We complete the crisis assessment tool. That might not have to be done. We do it with the youth and family. So while we're sitting there, we're asking the family, because the crisis assessment tool really is a self-report tool, that the family is giving us the information. So we're going through the tool asking those questions based on how the family has told us their story. I always tell people a good response worker learns this crisis assessment tool. Why? So that I can complete this assessment with the family in a conversation. So it doesn't feel like when we're going through the assessment process that I'm checking off marks and I'm not really engaged and in conversation with them. Then we develop a family care plan with the family, and that's about leaving the family with something that they could work on when we are not there. And I'm going to talk a little bit more about that family care plan later on, because that family care plan should be more than if you start to act up, call us back. That family care plan really needs to give families things that they should do reactively and proactively. And I'll talk more about that later on. But what I see a lot of people do, you call it the family care plan, we would call it a safety plan, is that we give family a family care plan that just identifies people to call. That plan really should support the family remaining stable during that time. So we need to outline, here's what family members can do when they see the situation is starting to escalate, or that we're not able to remain calm. Here are some things that we should do before we call other people. So even when we create that plan, we need to have a discussion with that family to see if they feel the plan that we're giving them, do they see that plan working? Do they see that they will follow that plan? I like to tell people this: we can develop any type of treatment plan we want, but until a family says that they're willing to follow and try to follow the plan is not effective. We have to hear that they're willing to be a part of the process, because from day one until the last day of stabilization, we are teaching them skills to manage their crisis themselves. So then we complete progress notes and pertinent documentation. I always stress that if you get nothing done on your first day of working with a family, a progress note needs to be completed. Why? Because if something arises and you no longer on duty, what is the person who is following up behind you, what are they going to know to do? So the progress note progress note on the day of service needs to be completed. I actually call that a non-negotiable, that I need a progress note at the least. The day 2, we need to check on the family to make sure that stabilization is okay. We need to determine if this family needs another level of care. This can be done on day 1, but I'm just saying you have day 2 to make sure if something else is happening, because we might be checking in and the family may start to see that you came in and the intervention you provided with the response is enough for them. Others might need continuing and additional support. So we need to check in to see how families are doing. If we see that this family just needed the intervention that we provided on day 1 and follow up, we will then start to talk about what resources will be available to support this family when we transition them out of response program, but we're not transitioning them into stabilization. If we are transitioning them into stabilization, we start to need to think about what it is that we need to write about, we need to talk about what supports they may need within stabilization, and we need to address that then. We also, if we go into a family and we recognize that this family needs a much higher level of care than stabilization, we need to start the wraparound consultation that we need to do and maybe submit it. Because a person may not be able to get into wraparound right away, then that person is also appropriate for us to transition into stabilization. So whatever needs to be done, we need to start to complete the required documentation. By day 3, we will know where the family needs to go, whether we want to transition them out of response into community supports and resources, whether we need to transition them from response into stabilization. If we have made the referral the wraparound, so we're also going to transition this person into stabilization if we cannot get them into wraparound right away. So we just want to make sure that we have that continuum of treatment and supports lined up. We want to ensure that progress notes are written. We want to make sure that the crisis assessment tool is completed. We want to make sure that there is an action plan that will help the family along the way. And then we want to confirm that there have been linkages and referrals have been made to ensure that the process is able to continue smoothly. Okay? We can then identify who the stabilization worker may be and transition the person to stabilization. I know that you already have a process set up that would say this is who the agency that you're going to work with, and this is when the appointment that they're going to contact you with. All of that should be set up before you actually transition someone out of treatment. And I use the word transition instead of discharge. Any questions or comments about this process? This process really will be more smoother because this specific process will come from the response from Nexus response worker. You know, you'll have it set up the way you feel is best suited. But this is what 3 days should look like. On those days, we have to check in to make sure that the family is actually doing okay. Why won't this? Where's my cursor so I can move it forward? Because there you go.
I appreciate Denise for you mentioning that continuity of care across the 3 days, right? And then having a progress note. So in case if the families call that somebody is not answering, and then kind of again making the family retell their story, but there is a continuation of the engagement that preceded. The second one, I think I can speak just for myself, having this training now, being this training compared to last year, that process was not really clear. And I feel this year where we are more attuned to that process and figuring out those connection points. So something that I think we take pride in some of those learned lessons from last year of we don't have all these processes really defined, especially considering this is not a singular agency that's doing that. These are three agencies, and then the level of partnership in that process and ownership of needs to reflect across that. I think we have done really well. I'm just, again, I just wanted to say thank you to everybody who is being able to look at those three, days and say, yeah, we already got this.
Yes.
Luan, you had your hand up.
Mhm.
Or did I miss somebody else?
Luan and somebody else was there too. Okay, go ahead, Luan.
Okay. Well, Denise and Paula, just going back to scheduling with families, what is I guess maybe you can delve a bit more into this. When we do get calls and the concern is either youth running away from home, so they are not present, or when they're being discharged from the hospital, or they are in an inpatient psychiatric facility awaiting discharge, and the family wants to meet with us. So there is no current crisis, but a more of a preventative sort of approach. What are your thoughts on that?
We actually do schedule appointments right away. That's what I'm saying. That is a place where you would be appropriate scheduling of intervention. If someone's getting out of the hospital, we recognize, and I'm only going to talk about from New Jersey, we recognize that a family member can sit in the emergency department in New Jersey. They could be there for days in New Jersey. You might not have that experience, but they could be there for days or they could be there quite a few hours. The least, and I mean the least amount of time that a person, a youth who goes to what we call screening, which would be your emergency department, the least amount of hours they would be there would be 5. And that's about 4 takes medical clearance, and then they would go in and see someone. And so what we have found that many times when families are sent to the emergency room, well, when they go to the emergency room, because we only send families to the emergency room where there is, a really psychiatric issue that cannot be addressed unless the person needs medication or admission to the hospital, or there's a life-threatening, suicide or something. In New Jersey, any issue outside of that, or really extreme behavior would be something that mobile would be called in before they would be sent to the emergency room. However, if a parent chose to take their child to emergency room without calling in and asking for mobile, or if they're getting discharged from the hospital, again, as a preventative measure, we would go out and meet with the family. And we would meet with them as scheduled, but we would still try to have that schedule within 24 hours because we'd like to support the family along the way. So there are times that we do actually schedule, but we try to minimize the amount of scheduling that we can connect it to children and families. We really, because we also have that if a parent is not available at school, then we might have to schedule a response time that's convenient for a family member at home. But we still try to stay within that 24-hour window.
So just following up on that, what if the concern is the youth being a runaway? And some families do insist, or caregivers do insist, that we meet with them. And what are your thoughts on that?
Well, is the child available?
No.
Oh, that is for us, we pretty much have children need to be available to do the counseling with the child and the parent. When the child returns home, we tell them we will be there, right? When they call us, as soon as the child comes home, we will go in. But most of our time is scheduled around having both people available. One, we cannot see a child without their caregiver. And 2, it's hard to do an intervention without the person there to find out what are the reasons for the child leaving. Because many times we need to know why is the child running away? What are they running to, or what are they running from? Those are questions that you need to address that the parent really can't give you. We also have other supports in New Jersey that maybe you don't have. We have a family support organization for parents that are actually struggling with dealing with their child's challenges. So if a parent is struggling with a challenge that they have with a child, we would refer the parent to the family support organization to help that family with the caregiver with challenges that they're having in that way. But for us, we are always seeking that both are involved and both are present.
It will really change your service, your system, if you start making appointments
It
with
will.
families on a
It
routine
will.
basis. It will definitely change the tenor of your organization. It really needs to be crisis oriented.
Mhm.
You know, and I know our billing depends on that, but you have to be careful because it will change the culture of, you know,
Mhm.
response if you start scheduling.
Too
It
much.
becomes more of an outpatient almost rather than a
A crisis response.
Mhm.
Yes.
Just following up on Luam's question.
Mhm.
If a parent, and I think this is where we differ philosophically, the New Jersey model and our Hennepin
Yes.
County model, is
Mhm.
that, let's say a youth is in a hospital, inpatient care, and the youth is getting ready to be discharged into the home. But the parent recognizes that they don't have, or the caregiver, they don't have the resources. So sometimes it's more of the knowledge base, or even somebody they can talk to that helps them understand the transition of the child into the home itself is a really pivotal time. So
Yes.
families, what they're asking us is, I know my child is coming from a either residential treatment center or from an inpatient setting, and I don't feel like I'm ready mentally. And we don't have the family support organization that
Mhm.
you refer to.
That's
So
what I'm
as
saying.
we don't have that infrastructure right now, we were saying that itself is a crisis that's going to happen.
It
Yes.
is. I
If a
agree.
Yes, it
youth,
is.
yep, if a youth is a runaway or is not home, and the parent we tell call us when the youth comes home, there are times when the youth comes home and the parent doesn't really know how to deal with that. So rather than try to support, and if the youth is coming home, that itself is a strength. If he's not coming home, it's worse, right? So sometimes when the youth comes home, the parent doesn't know how to deal with. So it creates a crisis for the parent and the youth, and then the youth goes back out again. So we
Mhm.
might never catch the youth and the family together, but that family, that parent is in crisis. And that's how we see a small number of families that are their youth are not in the home, but are needing support that we were able to connect with because we don't, in the absence of family support organizations,
Mhm.
we're doing both at this moment.
Okay.
And
All right.
Okay.
And I agree with you that there are that the family is in crisis. And especially when people, and so here in New Jersey, when people are leaving treatment, they do have the ability to have mobile come out. So that's the process. That is part
That's
of our process
automatic,
of it.
actually.
So
That's
we
automatic.
actually do go out for those times, but we still put we do it within 24 hours because what we don't want to give the child a chance to come home and they go right back into old behaviors, which then results in the child being removed. But we still do require that both people be present because we want to work with the child and the family together and not separate. But so that is part of what we do here. But the runaway, we do expect that the child is present when we come for the runaway.
Go ahead, Kayla.
So I just want to quickly throw out a comment for this for today, as well as next for Friday and our next trainings, that as we kind of go through some of these concerns or issues or see these differences, I want everybody to remember to continue to do things that we have already implemented for our policy and
Exactly.
procedure, because we are going to
Exactly.
see some differences. And I know that as we hear different things, then we may be like, oh, well, Denise and Paulette said this. So just if any responders have questions, any of the stabilization providers or any of the other organizations, to make sure that we continue to connect and do the things that we're doing in the way that we put it together, unless when we meet as a group, we make some changes based on information and feedback we received from Denise and Paulette.
Yeah,
Thank you.
we have funding issues. And the other thing we always tell people is listen to your supervisor.
Well, I hope
Listen
that we're
to your
saying that's why I'm
supervisor.
trying to put out that we're different. But I'm not trying to tell people to change really much. That's why I said protocol is your protocol. I'm just giving you what our practice is. Okay, thank you, Kayla, for that.
Automatically go out for is if there's a change in placement for a child that's in foster resource.
Yes. We
automatically go out. There's a call made, and we go out to the new family where the placement's taking place, and work with the child and the family to transition them together.
Mm-hmm. And we might extend our stabilization longer than you do. So I'm not even going to go in that. There was someone else who had their hand up, but I can't remember who it was. Okay, so I'll move on. We're getting closer to the end. Okay, I hope these conversations are helpful as we try to move forward. Yes.
I
So,
love your care for the family, so I really appreciate it. And you're
yes.
right on that. You could know a family's in crisis if their child's not home and where they're supposed to be. So,
Okay. Yeah. At this exercise, and I think, Paulette, because of time, I'm going to move past this and we'll actually come back and do this exercise another time. But really, and this exercise is more so for, well, it might be people who haven't been here. I mean, who've been here for a while, but the next exercise was, what is your elevator speech when you go out and you're actually working with the family? How do you tell them about what you're able to do? I think that is something that maybe we need to practice at another time. What is your elevator speech? How are you telling people about mobile response? Because families need to know who you are and what you do. And the reason why we asked about that exercise is because if a family has had prior connections with any other system partner, they actually see you as an extension of that system partner. And with them not having a clear understanding that you are not that system partner, it can actually impact what information they're willing to give you and how your relationship actually develops with them. And so we were just putting the exercise in here, but I'm looking at the time constraint and it's almost 12 there right now. So I'm trying to be mindful of the time that maybe that is not the exercise to do right now because it would take up more time. So I'm going to move on and get in one or two more things, and then we can save that for the next time. I'll be mindful of that the next time. Okay. And I'm going to move on. And this takes a while for it to move. So here it is. What did you think about when you actually hear the word crisis? I just like when you are working in the work that you do, and now I'm going to go randomly around and just ask, when you think about crisis, what actually comes to mind for you? And I'm going to call on people. I'm going to be real honest. So quick answers are always good. So, Goldina, is that how you pronounce your name? And if I don't pronounce it correctly, please correct me.
Yes, that's how you say it.
Okay, Goldina, what do you think about when you hear the word crisis?
I think of an immediate situation, just to summarize it together, yeah.
Oh, immediate situation. And how about you, Alexandria?
When I hear it's a crisis, they need us. So we are on our way.
So you're needed right away. And how about Jackson? Let me get
When I think of crisis, I think of the word intense. Like, that's what I think of, just intensity.
Mhm. And so I want you to think about it. So when we talk about crisis, crisis might be something that actually overwhelms the family or the people's ability to respond to a situation in a usual way that they would do on a typical day. That I have been overwhelmed by what is happening to me at this time. But I also want you to think about it to take it to the next level. That crisis can also be an opportunity for change to occur, for new learning, new ways of thinking and learning, and new patterns, and developing of new habits. So I want you to think of it as that, yes, here it is. We're in a situation where people are really struggling with what it is that they need to do for this particular situation. But I also want you to think that, hey, this is an opportunity for them to learn to think about and do things absolutely different. So we think about crisis as an opportunity, also as a danger, because we also know that in crisis, things can become out of control and can become dangerous. And so we always have to have all of that in mind when we go to respond to a crisis. And how many people get butterflies so they can tell when they're getting ready to go? Right before you go out, you know that something is going on. That is a good thing. For many people, they think, oh, why am I feeling that way? But that is your body amping up and getting ready for the unknown. And so we always have to be all right with that feeling. We can't never want to make that feeling go away, because that feeling helps to guide how you respond in different situations. So the one piece of advice that I want to say before I move on and we get deeper in the conversation, because we don't have the time, in doing the work that we do, whether you're doing crisis or stabilization, we all have to learn to follow our gut. Because when we go against those internal feelings, that gut, we tend to make really bad decisions. That feeling that you get prior to your responding is telling you to actually pay attention and to be on alert and to follow pretty much your first instinct, not your second. Okay? Why the first many times and not your second? Because the second starts to work on logic instead of instinct. Does everybody follow where I'm coming from? You get somewhere, and I'm just using our environment because I'm not really visually thinking about yours at often. We live in the area where there are a lot of apartment buildings, okay? So you have to take an elevator to go upstairs. You go up to an elevator, you're a female or you're a guy, I don't care who it is, and someone's on the elevator and your gut says this is uncomfortable. Who gets on the elevator? I'm glad nobody raised their hand, because if your instincts are telling you that this is an uncomfortable environment, you need to follow that instinct. And what happens a lot of times is, in a crisis, people then start to second guess their instincts, and they say, okay, well, I don't want people to think something. No, when we're doing crisis work, we have to remember that those instincts are there as a safety mechanism to keep and support us in making good decisions. So if you see something that's unsafe, then you don't keep walking into it, you walk away from it. Any questions or comments about that? I just thought that's what came to me when I thought about crisis, that we need to be mindful that our instincts are there for a reason, and we have to learn to respond to them. And I can tell you from doing crisis work for many years, and I've done crisis work before I start working at Mobile Response. I worked in other environments that had me to be very aware of those instincts, that it was important that I followed the first one. Go ahead, Joshua.
So this might not be the best question for when we have about a minute left.
But okay.
But how do you reconcile that with our, oh God, I can't remember the exact word, but our gut reaction to our biases and our gut reaction to, you know, things that we were acculturated with since we were young. I grew up in a very small, very white town, and as a result, I have to fight back against some innate biases that I grew up with.
Okay, and I'm going to say that that's something that you recognize and that you have to identify and be mindful of when you do the work, because all of us have our biases, whether we grew up in an environment that is pretty much isolated and very homogeneous, that everybody might look like ourselves, but we can still walk into those environments where people look just like us, and something in that environment tells me that I need to take a second look at what's going on. I get a feeling that there's something going on. So in our work, we always have to do a couple of things, and I'm going to stop because you're right, Josh, this was a long question for a minute. I'm going to recognize that those things are present, that my environment that I was raised in may impact some of the beliefs that I have, and I'm going to question them not only when I'm in a bad situation, but I'm going to question them before I get put in those environments and be aware of them, so that awareness is present. But I also want people to talk about, when it comes to safety, that we keep those things in consideration, because there are things that you listen. I like dogs, but I don't like everybody's dog. Okay, you understand where I'm coming from? And so when I'm in the environment and I walk in the environment and there's an animal that makes me feel uncomfortable, I'm not going to push through the discomfort. I'm going to speak about the discomfort of asking someone, can they remove their dog? You understand what I'm saying? Because I recognize that there's something that's not right for me. Now, I'm saying culturally, we have to address those issues. You should be addressing those issues prior to doing the work. But sometimes culturally, you have to pay attention to those issues also. I'm not going to say don't take everything that you have and just throw it out the window. Recognize that there's some cultural biases that we all have, and we have to deal with that. And that will show up in a lot of different ways. And we can talk more about that later, because I went 2 minutes over, and I hate to go